I want to thank you for having the opportunity to share some thoughts on Marfan syndrome and related diseases. I try to put in the title slide the major idea that I try to get across. You can see a very severely diseased Marfan boy is so-called neonatal Marfan syndrome with affected eyes, hearts, and so on. We will come to this later on. And I will try to explain how we in clinical practice as cardiologists working in a multidisciplinary team together with geneticists, we try to combine information from genotype and phenotype. And I want to tell that we never can alone manage patients with genotype information and never alone today in the era of genetics alone with phenotype information. But the combination of both is what really makes modern management in these diseases. And I will try to show briefly how this can work. So in the first place, before we enter into the main topic, I wish to explain that all diseases that we talk about now are today called heritable thoracic aortic disease, which is the abbreviation HTAD. These syndromes are divided by either they are symptomatic or syndromic, or they are non-syndromic. The syndromic HTAD diseases are Marfan syndrome, Lou-Stitz syndrome, and vascular Ehlers-Danlos. All these syndromes have aortic disease as their common problem. In the non-syndromic HTAD diseases, we have exclusively aortic disease or dissection, aneurysm of the thoracic aorta, or dissection of the thoracic aorta that reside from different genes. And here we have two kinds of diseases. The first is non-syndromic variants of syndromic diseases like non-syndromic FBN1, say Marfan diseases, and others that come from specific genes that are unrelated to syndromic diseases. So this is the spectrum and the nomenclature of diseases that we talk about. Now, I have 5 points that I want to discuss briefly. First, is it possible to diagnose these diseases without genetics? I want to tell that earlier diagnosis results in longer life. I want to show that early gene test has a higher impact, and genetics for clinical predictions is important today. And nevertheless, clinical predictions are mixed calculations. So starting with the question, diagnosis without genetics. If we look at Marfan syndrome, we have a clear guideline that is the so-called revised Ghent nosology, and you can see that it's a combination of family history. Are other members affected with aortic disease, yes or no? And does the patient have aortic dissection or at least a dilatation? Does he have ectopia lentis? Does he have systemic affections such as severe scoliosis or dural ectasia or whatever? It's a list of a couple of manifestations that are listed in the nosology. And do we have a pathogenic variant in the causative gene, which is the FBN1 gene? And you can see that there are only 2 diagnostic situations where you obviously need a gene test to diagnose Marfan, whereas the remaining 4 or 5 conditions or constellations you can diagnose Marfan syndrome without using a gene test. But it's different if you look at Lou-Stitz syndrome. Lou-Stitz syndrome too has systemic manifestations, has aortic diseases, and so on. But the most popular proposal of how to diagnose Lou-Stitz syndrome, there is no real consensus, is to look at genes, at causative genes, and then to give it a diagnosis if there is some other symptom, and it may be a minor one. So here, Lou-Stitz syndrome is for the majority of experts today based on gene diagnosis. And if you look at non-syndromic HTAD, you have a patient with aortic dissection. It may be familial or it may be sporadic, and it may occur at young age. But you don't have any proof that this isolated thoracic aortic dissection or aneurysm actually is a specific HTET. And only with a gene test, you definitely know that there is a genetic background. And you can't diagnose it differently. So next question, early diagnosis, longer life. This is a very, very important thing. And I show you data from the Hamburg experience that we actually analyzed in preparation for this little symposium. And we analyzed within a 10 years period the proximal surgery that has been performed in HTET patients. And you can see that 200 elective surgeries that were performed prophylactically to avoid dissection, they were all with a diagnosis of HTET before operation, whereas all those patients with acute and potentially lethal acute aortic dissection who were operated on an emergency condition, which were 100, only 4 patients were diagnosed of Marfan or other HTETs before the event happened, which means that only if you have an HTET diagnosis early, you have the chance to operate early and to protect people against lethal dissection. And you can see that the early diagnosis results in better life expectancy because, of course, you avoid emergent operations. I'm not talking about the quality of life, which is much better if you do early diagnosis, but this is simple survival. Now, the question is, of course, if you say, well, we need to diagnose early, the question is how? Because most or many patients with genetic aortic disease are only oligosyndromic. You don't see much, or they are just like a needle in the haystack. It's a rare disease. How do you pick up a patient without severe complications? And for Marfan syndrome, we have the 7-sign score, where simple 7 questions, and we posted them on the ERN POC of knowledge or pills of knowledge data bank, so that any person in the population can make a little check whether he has or she has a likelihood for having a Marfan syndrome. And we have early warning signs also with lustidsum. There's no real statistics that we performed, but you can see this hypertelorism. Thanks for Petra Gehle, who gave me this picture. So you have these wide eyes, you have those gross hands and feet, or if you look into the mouth of such patients, you may have bifid uvula. And some young people with chest pain, you see in the emergency room, and you tend not to do an imaging. If they have this finding in their mouth, you may do a CT because this patient has a Lustitz syndrome. So this is very important. And Eleftheriades looked for early signs in the literature in patients with non-syndromic aortic disease. And you can see here also you have a couple of findings, associated malformations like cerebral aneurysms, isolated or simple renal cysts, bovine aortic arch, and so on, that all may ring the bell for looking at the thoracic aorta and to search for aneurysm, and maybe then to diagnose HTET. So earlier diagnosis, longer life. Next, early gene test has, or the earliest gene test may have the highest impact on management. So we have 3 diagnostic situations. We can perform a genetic test before symptoms happen or are there. Or you can do it when symptoms are present, and you can also do it when complications have evolved already, which is confirmatory testing. If we look at these situations, first, of course, predictive testing, I did in preparation for this little symposium, a little questionnaire, quick questionnaire among experts in Germany, Tom Meir from Hamburg, Sibylle Singer from Münster, Harald Kämmerer from Munich Heart Center, Petra Gehle from Charité, and Klaus Kallenbach, Heidelberg, now Luxembourg. And you can see that most of the colleagues would say whenever they can, they would start medication to prevent aortic dilatation, even in pre-symptomatic patients. And you can see some colleagues are a bit like Sibyl Singer, a bit more reluctant, but they would also start with mild dilatation when other risk factors are present. And Klaus Kalmbach and Petra Gehle only does it with shared decision together with the parents, but she does it as well. So most experts are, although data are not really present for this predictive or pre-symptomatic medication, most colleagues agree that they would start medication when they have a positive gene test in a young patient, not yet having an aortic dilatation with a high probability to evolve into Marfan syndrome. If we look at diagnostic testing, here you have a young guy who has been operated for aneurysm and who has a very typical phenotype of Marfan syndrome. You can see that the clinical features like tau stature, arachnodactyly, pectus deformity, aneurysm of the aorta, mitral valve prolapse, and striae all argue for Marfan syndrome, but they all argue for Loos-Dietz syndrome as well. So that on a purely clinical basis, you may diagnose Marfan syndrome here, but you may also deal with a Loos-Dietz syndrome, but you don't know. And if you do a gene test and you have a mutation in the FBN1 gene, you clearly know it's a Marfan patient. If you don't have a mutation there, but instead in the TGF-beta receptor 2 mutation gene, for example, you can be sure it's a Loos-Dietz syndrome. Now you may ask, well, okay, so, but what's the big deal? It is a big deal because if you treat a Marfan or whether you treat a Loos-Dietz patient is very different because they have different prognostic profiles. A Loos-Dietz patient has a likelihood to develop sometime in his life or her life an aneurysm in the cerebral vasculature arteries. And the Marfan patients have as exclusive feature ectopia lentis, which does not occur in Loos-Dietz. So it has different implications for management, and that's why you need, even for diagnosis, a gene test. Now, for corroborative testing, we could say, well, if you look at this little boy and you may look at his story, it is really heart-shaking, the parents who loved this little boy who has a severe neonatal Marfan syndrome with a very grave prognosis within months. You can see, well, you could say, well, what about the diagnosis? I mean, this boy has to have aortic surgery, he has to have mitral valve surgery for severe regurgitation, or he may not have it, but you know, the requirements are clear and the phenotype is clear. So why do a testing? Well, there are two reasons. The first is parents may have, even in these sporadic mutations in the FBN1 gene, a probability of getting another child, which is small because it's a germline mosaic, but they may have a risk to have another child with Marfan syndrome. That's the one. And having a diagnosis gives psychological stabilization to those who are dealing with the problem, especially the parents. And I think these are two very important reasons to even perform corroborative testing in these desperate situations or clinically clear situations, as it may appear. The next is genetics for clinical predictions. What can we use gene information to predict clinical outcomes? And there are three levels how we can do it. The first is, you can see here a sketch of the functional domains of the FBN1 gene. You can do it by a specific mutation type in a specific gene. But you could also ask, well, there are many causative genes resulting in HTET. Which gene is it, and what does it tell us about the prognosis? Or you could simply ask, well, you perform a gene test, and is it positive, or is it negative, or is it unclear? And what does that mean? just on this gross level. And I will highlight the first one, prediction by type of mutation in the FBN1 gene. Much research has been done in the FBN1 gene for phenotype-genotype correlations. Many of you in the Charité may remember Peter Robinson, who worked on this hard. Now there are other people in Europe who do it, like the French people, and they analyzed 1,500 FBN1 mutations, and they came up with a sketch of, or now this little profile of risks that depend on specific types of mutations. So they even propose this little chart that they propose to use for genetic counseling. But you can see that this genotype-phenotype story is evolving. You can also try to predict by gene, so which gene is affected. And in Germany, we work together to make some quality tests on our genetic testing and predictions. And here we have some data on more than 1,000 patients with a mutation in ATET genes, and you can see that the difference for the aortic prognosis between FBN1 and all other HTET genes is not significant. However, if you look at other organs, and I take here mitral valve surgery likelihood as an example, you could also look at the eyes, you could also look at the skeleton, and so on and so forth. But you can see that here, the question which gene is causative really tells you something about the prognosis. So for prognostic profiling, it is important to have the causative gene. And the next question is, what does a positive or a negative gene test, whatever gene of the ATET variants, what does it tell you? And you can see the gross distinction, a positive gene test or a negative gene test has a significant difference, for example, in the likelihood of getting or needing a proximal aortic surgery. So there is, the gene test is very important in this respect. And you can see the decision of a clinician not to perform a gene test has a good prognosis. And on the other hand, those people with an unclear test result, VOS, there are some with a very good prognosis and others with a bad prognosis. So, which means that we have to force things here and to go deeper into those patients with unclear gene test results. But you can see that a positive or negative gene test or an unclear result really have prognostic implications. Now, finally, clinical predictions are not based on genes alone, but they are mixed calculations. Of course, you have a gene that is, when mutated, the etiology for aortic disease. And nonetheless, usually with rare exceptions of aortic dissections already before birth, which happens in some serious mutations, you have a long way, like 30 years or so, until the phenotype of aneurysm or even overt dissection is developing. And you need a lot of other pathogenic mechanisms that propel the development of aneurysm and dissection. And on all these levels and mechanisms, you have possibilities to intervene. And you can see here at the list of risk factors that allow for estimating the clinical risk for developing a rapid aneurysm or dissection is very long and ever evolving. I don't go into all these issues, but it's very important to look at these things in detail besides genes. Now I summarize that the diagnosis without genetics, yes, it's possible in Marfan, it's not really possible in loose Dietz, and it's definitely not possible in non-syndromic HTET. Earlier diagnosis, longer life, we have shown this, and we have emphasized the importance of early warning signs. Early gene tests, high impact. We have those three different diagnostic situations where all a gene test plays a role. We have seen that genetics is valuable for predicting phenotypes, but we have also seen that there are a couple of very important clinical predictors as well. So these are my conflict of interests. They are none. And I want to thank you very much for your attention. If you have questions, if you want the slides, if you have comments or whatever, you want to join the German project for MAFAN and aged head care, just give me an email, kodolitsch@uke.de, and I will be very happy. Thank you very much.
Thank you very much for this presentation on MAFAN. I think this was covered every aspect one can imagine, and I'm checking if we have any questions here in the chat. So far, I don't see any question. I think everybody is hoping for a lunch break now, but maybe the other speakers might have a question. I don't know. I think it was very important. No, it was very important to point out that it does not necessarily need a genetic test. So it's always good if the clinician knows what to look for, and that there is the possibility to make a diagnosis without a genetic test. But in the end, you also mentioned that genetic testing can help in some ways also regarding the medication so I think that was really important, especially for the younger colleagues, I guess. I'm not a cardiologist, but I hope that they really benefit from your presentation and your experience.